which we'll get into. So instead of feeling like you're at the mercy of your disease, you don't know what to do when symptoms rise, you know what to do depending on what your peak flow says at the time. Asthma triggers, you're probably familiar with most of the allergens here. What's interesting under them is most asthma triggers actually trigger pre-existing asthma. It has been shown that cockroaches will actually cause asthma to exist in people who are exposed to them long-term who don't even have asthma before. So in the inner city, cockroaches are a huge problem with asthma triggers. Irritants are also huge. One of the worst asthmatics I've ever cared for in ER, who ended up doing okay and not going on a ventilator and not coding, had been cleaning her shower, and shower cleaners are notorious. She barely was able to call 911 before she couldn't have even gotten a phone call out anymore. They brought her in her pink robe. Respiratory infections, the ER docs that I've talked to about asthma flare-ups say that is the #1 thing that they see down in the emergency room, is people coming in with all the respiratory viruses, especially in the winter. On medications, a beta blocker is going to block the medication, the beta agonists that we use to relieve bronchospasm. So I actually just saw this a couple weeks ago in the ICU. I had a patient who had PRN albuterol ordered and she hadn't needed any. And at the beginning of my shift, the nurse called me over and she was wheezy. And my first question was, what's changed? She goes, well, I did start her on a beta blocker last evening. So that works against our beta agonists. Also, any asthmatics who have an aspirin sensitivity need to avoid all NSAIDs as well. This will not just cause an allergic response, but it'll cause an asthmatic response.
So you're saying that patients that are on a lot of asthma medications, taking ibuprofen or aspirin or being put on a beta blocker, could decrease the effectiveness?
Definitely, if they're on a beta blocker, can decrease the effectiveness of the beta agonists. So that's something that the physician really needs to look at. The aspirin or the NSAIDs are only for patients that are aspirin sensitive. Good question. Other triggers, of course, can be strong emotions, cold, especially the cold in Montana in the winter when you walk out and it's so cold and you breathe that cold, dry air down. Medication administration. This is probably similar to other chronic diseases also. Right time for the right reason taken correctly. The problem that we run into with respiratory medications is the controller meds need to be taken regularly and the rescue meds need to be taken PRN. And for some reason, people don't like to follow that. One of them is the controller medications are really expensive, and the rescue medications give them quick relief, so they think that's all they need to carry with them. Another thing is a proper technique for each inhaler, and this is a huge issue. At least 80% of the time when I'm working with somebody with their inhalers or even giving them to them at the hospital, I'll say, do you know how to take your inhalers, or have you been taught? And the answer is almost always yes, and 80% of the time they don't take it correctly. So briefly, for canister type inhalers, they need to have an aero chamber. Twice as much of the medication gets deposited in the lungs with an aero chamber. Yes?
I work in long-term care, and I would say 90% of our residents use aero chambers, so pretty effective then.
It's just you would get twice as much of the medicine deposited in your lungs. And the reason we know that is we tagged the medicine and either measured what comes out in the urine or looked at it tagged on a chest x-ray. And if you don't use a spacer and you put your lips right up around his, most of the medication's going to hit the cheeks and tongue and never have a chance to break up into the small particles that are just the right size to be carried down into the lungs and then deposited before you exhale. So before spacers came out, we used to tell patients to hold the inhaler about an inch away and use what we call the open mouth technique. And if you ever watch somebody take an inhaler with the open mouth technique, you can see the medicine going out into the room around their mouth. So what a spacer does, or an aero chamber, is it captures that medicine so it's not lost into the room, but it gives it a chance to break up into just the right amount of particles that go down into the lungs and rain out there. Okay. So it's shaking it, one puff for one deep breath in. We have patients all the time that are rapid firers, and I'll hand them their inhaler and they go, it's like, dang, 5 of them in 1 second, you know? It's kind of amazing. So it's one breath, one push at the beginning of a slow, deep breath in. And hold that deep breath in for 5 to 10 seconds and let it out, if at all possible. If you're real short of breath, you're not able to hold it in that well. But the main thing is with the canister type inhalers, it's use a spacer and it's a slow, deep breath in. What a lot of patients aren't told is the dry powder inhalers, it has to be a fast breath in. Because if you do a real slow breath in, you're not even going to suck that dry powder out of here. Another thing with this type of inhaler, this is Advair, there's Ceravent, there's some of the others, is that once you open this and cock it, you've punctured the little packet of dry powder medicine in there. If you do this, put it down on the bedclothes, pick it back up, you could be spilling that powder out. So what I tell the pediatric patients is once you've got it like this, hold it like it's a hamburger that you're about to eat. Hold it nice and level, then cock it, fast breaths in. As long as you're not closing it and recocking it, you can take a few fast breaths in on it and you're not getting more than 1 dose. The other thing after any inhaled steroid, of course, is you need to rinse your mouth out, especially if you're on antibiotics to prevent thrush. You can rinse and spit, or you can swish and swallow, and actually that's more effective because if you swallow, it's going to try and rinse some of that inhaled steroid out of the back of the throat also. So I have for you a demo on asthma technique.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. Anna, you try twice as hard to fix them. You using your inhaler?
All the time. Go through 1 a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Isn't that great? I love it. And hence, that's what we look like once in a while. Okay. Asthma management, what we're going to look at here is a rule of 2s. And that tells us if an asthmatic is well controlled or if we need to step up or step down therapy. The rule of 2 is if you're having symptoms, shortness of breath, wheezing, more than twice a week, if you're using your rescue inhaler more than twice a week, or if you're being woken up by asthma symptoms more than twice in a month, you've broken your rule of 2s. Okay? So if you've broken it, not well controlled, the asthma that you think is intermittent might be persistent. If it's already persistent, you might need to step up therapy. And if you not breaking the rule of 2s and your asthma's been stable for 3 months or more, you may be able to step down therapy. So this is a real busy slide, and luckily we're not going to cover most of it. I don't seem to have a laser that's working now. It was a few minutes ago. If you look across the top of the slide there, where it's got intermittent, mild, moderate, and severe. Mild, moderate, and severe under persistent. Intermittent is somebody who can go for weeks or months without asthma symptoms, but they still got the asthma there. They still have the airways that are hyperreactive. On the left-hand side, under symptoms, nighttime awakenings, and short-acting beta agonists, those are the 2s right there. They need to be, like I said, less than 2 days a week for the symptoms, and rescue inhaler less than 2 times a month even for nighttime awakenings, because that's such a significant symptom. The lung function, we won't get into too much. That's the pulmonary function test that we can also help to stage asthma severity. If you look across the bottom of the slide, there's recommended steps for initiating treatment. So the intermittent asthmatic will start at step 1, mild at step 2, moderate at 3, severe at 4 or 5, and we actually have a 6-step treatment option there, and anybody on step 6 is really not doing well. But we start out usually on 1 through 4. What's your first line controller medication for asthmatics? Anybody? Caffeine? It's inhaled corticosteroids. Okay, first line controller, not a rescue medication. Remember in the definition of asthma, there was inflammation in there twice. So it's huge inflammation disease, and inhaled steroids are the #1 agent, and I'll show you when we look at how we treat each stage of the asthma. It is so important for anyone with persistent asthma to be on inhaled steroids that if they can't take it for whatever reason, the guidelines say they need to have prompt referral to an asthma specialist so that they can try and be controlled with something else. What controller medication should never be used alone for asthmatics, but it's okay for COPDers? And this one is the long-acting beta agonist, which I'll refer to as LABAs from now on. That would be like salmeterol or Ceravent. There are a couple others that came out after Ceravent, Foradil, and Brovana is a new one. They can only be used with an inhaled steroid for asthmatics. And the reason for that is Ceravent actually has a black box warning on it with deaths associated with it with asthmatics. And they're not totally sure why that has happened, but there's 2 good reasons that we've come up with so far. One of them is that patients might be grabbing their long-acting beta agonists when they're having an asthma flare-up and it's not working fast enough for them. The other reason is that the LABAs are probably masking the inflammation that's present there, and you don't know how bad that is, and without that inhaled steroid on board, when an asthma attack occurs, it's been fatal many times. So asthmatics should always be on an inhaled steroid with a long-acting beta agonist, but COPDers can be on a Ceravent or a LABA alone. All right, so this is the different steps and the different medications that we give at each step. We can step up if needed, and then we review with the patient. If they're on step 5 or 6, we give them maybe 1 to 2 weeks before we check back with them again and see how they're doing. If they're stable, 3 to 6 months, depending on it. Notice at the bottom of each step, patient education and the control of triggers and the management of any other comorbidities is important on every one of them. Because this slide is real busy, I've broken down the different steps into easier slides to look at. What I'm not going to cover on those are some of the alternative medications. I'll just cover the first line meds. But some of the other things that are used down here are mast cell stabilizers, because those are going to cause inflammation. So the LTRAs are leukotriene receptor antagonists, and those are like Singulair. They're going to help with an allergic response that triggers asthma. Theophylline is a methylxanthine. It was used decades ago. It's not used an awful lot now. And if you look at step 5 and 6, it says consider, okay. I can pronounce the trade name, which is Xolair. Can't pronounce the generic name. But what that is for patients who do not have well-controlled asthma and they have a highly allergic component, it's an injection that's given in the doctor's office every 4 to 6 weeks. And it helps stabilize that allergic response that's been triggering their asthma. So intermittent asthma, everybody is going to have a SABA, which is short-acting beta agonists such as albuterol as needed, and monitor peak flows. The intermittent asthmatic doesn't need to be on any controller medications. Persistent mild, immediately we go to the